Okay. Hello and welcome to the Scaling Sleep Solutions Show. I'm your host, David O'Daniel. My family runs a sleep technology company here in the DMV area for the last decade or so. And recently we've been looking into new technologies that are being created for diagnosing and treating sleep apnea with the goal of helping sleep practices to adopt them and improve patient outcomes and also to ultimately grow their practice. And so today I have a guest who I'm really excited to speak with. Um, he's somebody who's been very involved in this industry, has a deep background, author of several books, written several hundreds of articles, for what I know. An entrepreneur, his last company was listed on the NASDAQ, as far as I've been aware. But his greatest accomplishment, in my personal opinion, is his beard, if I had to pick out of all of them. So, Dr. Dave Singh, how are you doing today?
I'm doing great, David. Thank you for that wonderful introduction. Very kind words that came from you there. So yeah, we're doing great, and yeah, I'm ready to rumble with any kind of question that you may have, and we'll take it as we go.
Yeah, definitely. And on that topic of, we're going to get into sleep, but on the topic of the beard, you gave me a new
Yes.
perspective about the beard last time we spoke. I thought would be interesting for people to hear.
Yeah, absolutely. So we have to look at it from lots of different points of view. And, here today we are scientists. We're looking at data and, verifiable facts. And so, what we have here is Homo sapiens. We have a whole diverse bunch of Homo sapiens all over the world. And what we have in common is our human genome. And that human genome that defines Homo sapien really kind of arose, let's say 30, 40,000 years ago, saying it is the best version that we can produce right now in terms of survivability, longevity, quality of life. And so what we have here is, two eyes, 10 fingers, 32 teeth. And what we have also is hair on the head and on the face, particularly for males, and in other parts of the body as well. Well, this physical form that we have has evolved to the best level of refinement that we can do for the last 30, 40,000 years. So my idea is, well, why would I mess with it? If I were to trim my beard, guess what? It grows back. So there's a message here that the body would like to have you in this form. It's the most natural form and go with the flow. So that's the conclusion I reached, and I feel very comfortable that way. And, there's a lot of things that come into that, grooming and cleanliness, but also attraction. And so there's a lot of good things that come into it, and we have a very comfortable lifestyle. And I think you and I both, as beardies, are doing great.
Yeah, I was considering trimming it the last time we spoke, but that made me rethink it. That made me think twice. I
Right.
hadn't heard a perspective like that.
Mhm.
Um, but I think that gets at the way that you kind of think about things. It's more of a scientific approach looking into history of
Mhm.
us as human beings. So I think that's a great little window into your mind. Um, but yeah, so as far as our particular topic, which is about sleep and sleep apnea solutions, I'm curious to know kind of what got you into, out of all the different things you could study, what got you into sleep and sleep apnea?
Well, it's a great question, and it's a long question. Originally from England, I was invited to come to the US as a professor, as a visiting professor. And long story short is that became a more permanent, kind of feature. So here I am as a US citizen, been in the US for about over 30 years now. And so my original area, the reason why they brought me to the US was to look at craniofacial anomalies, things like cleft palate and craniofacial microsomia, all the kind of exotic stuff that you don't see very commonly. And so I was very privileged to be working in the Center for Craniofacial Disorders. It was an integrated clinic with the plastic surgeons, the orthodontists, the speech pathologist, all working together on these little babies and children and teenagers who had these craniofacial anomalies. And part of the things that we were looking at to say, what kind of surgeries can we do to make these kids look within normal limits? That was our kind of base thing. And we were doing a procedure called distraction osteogenesis, which in those days was a new procedure. We were probably one of the first groups in the world to do it. And essentially, we were bringing the face slightly forwards in these children surgically. It took about 6 weeks to do that. And my job, part of my kind of role there was to review the post-surgical results to find out what we found. And I was looking at the MRIs in those days. And what I found is that there were some significant changes on the MRIs. But the reason I looked at the MRIs is because when these kids came back for review, they would be smiling, they're making eye contact, they had self-confidence and self-esteem that I hadn't seen before in this group of kids. So I thought, I wonder what's going on. We know that they look a lot better than they did before the surgery was done. But when I looked at the MRIs, what I found is that the airway had increased in size exponentially. By bringing the face forwards, bring the jaws forwards, all the extra space allowed the airway to fill that. And my conclusion was that, hey, I think these kids are sleeping better. And because of that, they feel better. And this is where that confidence is coming from. And so that took me slightly away from traditional craniofacial kind of components into airway, breathing, and sleep. And the long story short there is that I want to get a technique where we could produce a similar result non-surgically, if at all possible. And that became my claim to fame, if you will.
Yeah, and that claim to fame, if I'm correct, so actually one of our mutual connections who actually introduced me to you is Joe Womack,
Mhm.
who we spoke with recently.
Mm.
And really early on when I was speaking with him, one thing he brought up with his kind of introduction to this world was he brought up your paper, the spatial matrix hypothesis. That's correct. So
Yes.
was that kind of part of this claim to fame, as you're saying?
Big time. So we need a unifying theory to say, hey, we just don't move the jaws or the teeth or whatever. What is the underlying unifying principle here? And funnily enough, comes back to the human genome. So this human genome is a blueprint, and the blueprint says, as I mentioned before, 2 eyes, 10 fingers, 32 teeth. Every human is going to have these components, but the thing is that they're going to be spatially arranged in a certain kind of positional kind of pattern, okay? And that pattern is going to play out throughout the individual's life from birth, babyhood, childhood, teenager, adult, older adult. All of these components will be working in a spatial matrix, a spatial pattern. So think about blood flow. You've got a tube and the blood is flowing through this tube. If you make the tube smaller, the blood pressure increases, and then you're going to get clinical, consequences because you might end up with hypertension, right? If it's done chronically. And same thing with the airway. If the airway is too small, there's not sufficient space for the airway to be functional, it collapses during the night. So the spatial matrix takes all of the craniofacial head and neck components, specifically hard tissues like bone, soft tissues like muscle, dental tissues like teeth, and then the functional spaces, which is the airway, the sinuses, into consideration to say this is how this pattern actually is kind of manifested in human life. So let's take the example of someone who has a small upper jaw. The palate is too narrow, not enough space to accommodate the tongue. So the human tongue is supposed to sit on the palate. Now, if the palate is narrow and too small, it's going to push the tongue backwards and downwards into the throat and therefore increase the risk of sleep apnea during sleep. So my idea was based on the surgery component, what if I expanded that palate non-surgically? And it became known as a DNA appliance, the first powerful expander to be FDA cleared for mild, moderate, and severe sleep apnea in children as well as adults. And so we increase the space, and that's the spatial matrix hypothesis to say You've got more space now. The tongue comes forwards, rests on the palate during sleep instead of falling back into the throat and causing obstruction. And so, that was an idea that took off, and I think it's helped quite a lot of people. A lot of development still to do, but it was a big step in the right direction.
Yeah, definitely, definitely. And that kind of goes into the next question, which is we kind of the history of sleep apnea. So what has kind of changed in our understanding over the years of what sleep apnea is, what causes it, what's happening when somebody's experiencing sleep apnea?
Again, a very comprehensive question, David. So we'll kind of pass it down to the basics here. So when you get a diagnosis of sleep apnea, you get an apnea hypopnea index of, pick a number between whatever it is. Okay. So let's just say it's 25 events per hour. So you say, hey, you've got moderate sleep apnea. Okay. But what we know now that we didn't know before is what led to that number. And what we found is that you can actually classify a subgroup sleep apnea into various types, endotypes. So some people have an issue where it's a neurologic component which is not allowing them to sleep properly. In some people, it's like a metabolic component. In some people, it's more of a craniofacial, like I just mentioned, the bones of the jaws and stuff. And then number four is the myopathic types, where it's a muscle tone issue. And so what happens is that when you do the sleep study, the apnea hypopnea index says, yeah, you've got moderate sleep apnea. But what it didn't tell you is what's the main motivating factor for you to have that sleep apnea. So let's say someone who has got a neurologic type of component, they've got a low arousal threshold. In other words, they fall asleep, but something during the night, they kind of come out of sleep, they get sleep fragmentation, they get arousal, and then they fall back asleep again. So they get non-refreshing sleep. They wake up in the morning, the AHI is like 25, and they don't feel refreshed. So one of the things that could happen is a neurologic component. So we have to say, why is this individual getting arousals? Is it sleep related or is it something else? For example, respiratory effort related arousals, RERAs. However, someone who's sleeping soundly and something goes bump in the night, it wakes you up, you get an arousal. That is different from a respiratory event. And so we have to look at the EEG very carefully to find out what is the, neurologic component in this case, and then address that as opposed to saying, well, I'll use, a generic approach such as CPAP or surgery or a device. Instead of a generic approach, it's a slightly more customized, tailored for that individual. The second group might be, metabolic cases. I'm using kind of a big kind of terms here just to think about people who are obese, high BMI, increased visceral fat. So what happens when these people sleep is that the visceral fat is actually pushing on the diaphragm, which is pushing into the thorax. And what's happening there is you are getting reduced lung volume, you're getting increased ventilatory load. It's harder to breathe. And so for these people, the reason why they have moderate sleep apnea or severe sleep apnea is because of this metabolic issue where they've got excess tissue pressure causing airway collapse. Because that visceral fat, although it's working on the abdomen, doesn't stay there. It obviously goes around the body. And what we know is that the fat is deposited in the pharynx, around the throat, around the airway, and it's actually deposited in the tongue as well. And so it's just harder to breathe because the tissue space that we need is occupied by fat, and that's causing tissue pressure. So in these cases, you say, hey, I want to fix your sleep apnea, but you might be a great candidate for, GLP-1 or GIP or some of these kind of weight loss drugs, medications to get sleep apnea under control. So there's two examples that we did not have, previously. And let's go a little bit further and think about the myopathic type of response where there is muscle laxity, the muscle tone is low, and the airway is just not strong enough to withstand the pressure, and it collapses during sleep. So the target here is the muscle tone. And there are some drugs and pharmaceuticals coming onto the market right now, which are directly affecting muscle tone to prevent airway collapse during sleep. And so the major thing here is that we are now breaking the generic kind of, diagnosis into these subtypes and trying to tailor, the treatment to meet that, bearing in mind there may be an overlap. So here's a guy, for example, or a woman, it could be anyone, who is, obese, but they also have a small jaw structure. They've got the chin, the mandible is retruded and recessed. And so you say, well, let me combine maybe the pharmaceuticals with a jaw advancement device. It pulls the mandible, the jaw forwards and keeps the airway open. So there may be combination therapies. Or it may be to say that, if I wear a mandibular device, I can wear a CPAP device, but I can turn down the pressure on the CPAP devices. And so we're moving away from, a single one size fits all into a more integrated approach where the sleep physician can work with the sleep tech, the dental tech, the dental provider, whoever happens to be, to say, we can give you a more customized approach to this. So I can go a bit further than this, but let's go a little bit more because you've hit a very comprehensive topic.
Yeah.
So let's think about this a little bit more. So you've got the idea of using this, combination therapy, but now we have to think about, let's look at, the apnea hypopnea index. Now, how
Mhm.
did that come about? Well, that came about, again, a kind of classification, a generic classification saying mild, moderate, or severe. But if we look behind the scenes, and again, this as a tech who's doing all the marking and the scoring, when the desats or desaturations occur, they can occur at different levels. It could be 90%, it could be 80%, it could be 70%. And furthermore, that desaturation could last for a minute, 10 seconds, 2 minutes, the interval. And so what we have to think about now is not so much the apnea hypopnea index, but also think about the hypoxic burden. How much desaturation occurred, to what depth, and for how long, because that is the pathologic impact on the system itself. We know that people who have deep desats increased risk of stroke, for example. And so again, looking at this, data that's coming out, big data, using AI to say, let me kind of classify or subclassify this a bit more precisely to saying you would be a great candidate for CPAP, or you would be a great candidate for something else based on the profile that we're seeing from the sleep study itself.
Mhm.
So let's think about CPAP, for example. The technique's been around a long time. It's the go-to kind of therapy for sleep apnea treatment. It's not going to go away anytime soon. And what we saw is different iterations of this technology as time's been going on. So the first idea was to modify this ventilator so it blows positive air pressure down your airway when you're asleep and prevents the collapse. And some people could tolerate that and some people could not. So then it went to like BiPAP, where the pressure that's applied when you breathe in is different from when you breathe out to try to mimic, inspiration, expiration. And it works for some people and not in other people. And then you go to something like AutoPAP, where we're trying to modulate the inspiratory pressure and the expiratory pressure, try to match something closer to that particular individual. And it works in some cases, or in other cases as well. Still, you got to wear the device, when you sleep at night. So now coming to physiology, how would the CPAP be most physiologically friendly? And that's a new kind of development called KPAP or kinetic
Mhm.
PAP. Okay, and the difference here is that you actually reduce the inspiratory pressure, and then when you are about to exhale at the end of expiration, you actually increase the expiratory pressure to prevent airway collapse at that time. Because what we know now is the airway is most likely to collapse at the end of the expiratory cycle. You're most hypertonic at that point. most likely to collapse. That is the point at which the pressure should be applied. And so that is a new kind of technology that is being talked about, saying, let's make CPAP the best version of, of itself. So there's some examples, David, of how we've started to look differently in terms of the diagnosis and also the therapeutic options.
Yeah. And so it sounds like we would almost kind of rethink not just how we're treating sleep apnea, but how we're diagnosing it. Like
Mhm.
what are the real metrics that we want to look at versus the general what we have, which is like you said, the apnea hypopnea index.
Mhm.
So just out of curiosity, do you think it would change anything about the actual methods that we use for diagnosis, like the PSG, which is kind of what we've been used to? Would it change anything about how we do a PSG study or a home sleep apnea study?
I think you've hit the topic on the head there. There is an explosion in diagnostic devices right across the market, the sleep apnea market. So it starts with wearable tech. So we got used to the idea of smartwatches, tracking devices.
Yeah,
Everyone's got one, right? And so it
yeah,
doesn't
everyone has it.
right? So now the consumer or the client or the patient can actually track and say, hey, you know what? I didn't sleep very well last night, according to my sleep app on my watch here or on my phone. And so that raises patient awareness to say, hey, I might have a problem with sleep. They take that tracking data to their sleep physician or their healthcare provider, and let's say they do a screening test like an Epworth or one of the kind of screening tests to say you have a increased risk of sleep apnea, then you do a formal diagnostic test. Now that could be a home sleep study, a HSAT, or it could be a PSG. But the difference here is it's a home PSG because the technology has become so sophisticated that some of the home PSGs are almost as good as an in-lab, study. And it's so much more convenient and comfortable for the patient because you're at home. Let's say the sleep test device is delivered to your home. You put the device on, you go to sleep, and the convenience is that the data is uploaded to the cloud, and therefore the sleep tech gets hold of the data, does a scoring, and then the physician can make a call on the diagnostic findings. So I think that's going to change dramatically, but there still has to be the in-person collaboration, consultation, even if it's done on a remote basis, rather than an in-office visit, to say, let's talk about your specific diagnosis and how we're going to approach it. So there has been an explosion in the diagnostic market. And when you add the AI capability on top of that, it sometimes becomes, wow, this is now working in the future because now we can do predictive modeling. So we can take big data and saying based on, facial features or a signal that we picked up from the sleep study, you would be a great candidate for this type of treatment. So there's a lot of information coming out and sometimes difficult to keep up with all of it. So for example, one of the newer techniques is hypoglossal nerve stimulation, kind of marketed as Inspire. And so the idea here is a bit like a pacemaker. So if you stop breathing, your diaphragm stops moving. So they sense that. And if that's the case, we have an impulse generator, which then sends, a signal to the tongue through an electrode, which then, is going to push the tongue forwards and open the airway. So the individual might be, suitable for that type of procedure if that is what we find with all this new technology coming in to make a very precise diagnostic call. Now we think, great, okay, well, what's the downside? Well, it's a surgical procedure. Number two, is it actually covered by your health, insurance, or is it going to be private pay? And so even though we have this technology that's emerging and going really fast, it doesn't exist in isolation. It's an ecosystem. So you have to think about how was the new technology marketed? what was the diagnostic steps taken to say, are you a suitable patient? Is this technology covered by insurance? Is it readily available? All of that real life kind of situation before you say, okay, you're going to be able to do this type of therapy for this individual patient. So we haven't kind of, solved all of those cracks in the system yet,
Mhm.
but it's waiting to happen. It's going to happen in the future because there's an increased awareness of sleep apnea, both in the US and worldwide. And what we know, what the studies are showing is that we really haven't reached the peak of the diagnostic um, curve as yet. We're expecting, between 60, 70, 80 million new cases in the next 5 to 10 years, newly diagnosed because of increased patient awareness. So the tracking devices, diagnostic devices are playing a big role in this and making it easier for more people to be diagnosed earlier.
Yeah. Yeah. And recently had a patient since I work the night shift, I do the PSG studies. I
Mm.
recently had a patient who was wearing an Apple Watch, and she
Hmm.
said her Apple Watch is what she would have never known. But
Hmm.
one day her Apple Watch alerted her like a sleep apnea alert, and that's
Hmm.
kind of what sent her down that path. So it's kind of exciting to see how like patients are being more empowered, I feel, throughout the process. So uh,
Correct.
exciting future ahead.
It's very exciting. Again, we haven't reached the peak of this condition, never mind, the world in the US. Now it's predicted that there are about 1 billion people who have a risk of sleep apnea worldwide. That's a huge number.
1 billion.
Yeah. And again, if you look at the demographics, it's like, who is going to be, diagnosed now and the future that was kind of missed in the past. Well, some of that would be, women and females, because you wouldn't suspect, a young non-obese female to have sleep apnea, but you can't rule it out until you've had actually a sleep study done. And so some of these younger people, younger women may have, upper airway resistance syndrome, which is going to kind of transform into sleep apnea as they get a bit older, because we know there's a kind of peak of sleep apnea incidence in, menopausal or postmenopausal females. So a disproportionate number of new cases may actually be women, simply because women tend to live longer than the male counterparts. And so as the population ages and gets older, increased proportion of women, increased risk of sleep apnea for some of the things that we've just mentioned. Now, also is a small sector that's been kind of overlooked to some extent is during pregnancy. And so during pregnancy, there's an increase of risk of sleep apnea in certain cases. It's transient. It's based on the fact that there's these hormonal swings and changes during pregnancy. There may be some weight gain during pregnancy, but after the fact, can we get these people to be recovered again and be healthy as they were prior to becoming pregnant? So there's some extra work to be done here. These are demographics that we have to look at very carefully and saying which of these niches in the overall general population do we need to address? And so, in the US, we've got a very diverse population of people. We've got people of African descent, Asian descent, European descent. So this is, a microcosm of the world map in terms of how these demographics play out in real life. So I agree with you. A totally exciting time to be in this field. We can do a lot to help each other and help a lot of potential patients.
Yeah, definitely. And as you're sharing, it's kind of making me look at certain cases I've seen. And so when you mentioned the about the pregnancy,
Hmm.
I have a friend who recently had a daughter, and he mentioned that his wife started to snore, like she didn't snore before, but started to snore.
Hmm.
So there are so many, like you're saying, there's so many different cases and different causes. But so now I'm kind of curious, like looking into the future of sleep apnea diagnosis, sleep apnea treatment. Where's your role? What are you kind of working on right now when it comes to those topics?
Well, this is a really good and timely question, David. So let's think about the kind of the development of sleep apnea therapy over the ages. We started off with, hey, you can use a CPAP machine. Great, excellent. You have to bear in mind that some of these patients have healthy lungs. They actually don't need ventilation per se. And so this is where we have to start working with CPAP in a more sophisticated manner to saying which are the best cases for CPAP. So again, if it works for you, great, it's great. Some of these cases I'm saying I'm going to use a mandibular advancement device. Where did that come from? Where did that idea come from? I don't know if you know this, but Dr. Horace Wells was a dentist in Connecticut, and he was the first doctor to actually do general anesthesia using ether way back in the 19th century. And so even at that early point, dentists were actually looking at the airway. And what we know is when a patient is under general anesthesia, we hold the jaw forwards to keep the airway open. And so that's kind of part of CPR as well. And so there's a whole big kind of, idea that we can use mandibular advancement devices to push the jaw forwards. My question when I came in was, well, why is the jaw back in the first place? So that's when I thought, oh, we have to think about the spatial metric hypothesis and think about the upper jaw being expanded and large enough to accommodate the lower jaw, the mandible, and the tongue that goes with it. So that's where the kind of oral devices came into the picture. And then we think about, some of the newer kind of ideas like electrostimulation. This is hypoglossal stimulation. It pushes the tongue forwards. Now we have a technique, a diagnostic technique, DICE, drug-induced sleep endoscopy. So it's like sedation, the mild step sedation. You put the endoscope down the nose and look at the palate behind it and the airway behind it. And what we find is that in some cases the airway opens front to back, and in those cases, if you pull the mandible forwards, great, the airway opens. But in other cases, the airway opens from side to side, medial lateral. So if you push the mandible forwards, it actually makes very little or no difference. So when you think about hypoglossal nerve stimulation, it's doing something similar, pushing the tongue forwards. But if this airway is configured to open side to side, that patient not going to respond very well. And so what the idea now is, it's called ansa cervicalis stimulation, where instead of targeting the tongue, you actually target the strap muscles of the neck, which surround the airway. And when you do electrical signal there, it's still a surgical procedure that opens the airway kind of side to side, medial lateral, and opens up these cases where you've got lateral wall collapse. So the technology is moving forward to understanding, I'm going to work with the patient's physiology. So then that got me thinking, how would the body open the airway if it was just normal and natural and healthy? How would it open the airway? And the answer is it kind of opens it medial lateral, side to side. That's the typical way of opening it. But if you've got the collapse of the side walls, I'll open it back to front instead as a compensatory method. And then I thought, let me look at the control mechanism for that, which brings me to the technology that I am working on right now. And I'm going to share my screen here. Let's see if I can share my screen and just walk through this idea. And let's just see if we can see this on the screen here.
Yeah, I see it pulled up now.
All right. So I'm calling this upper airway homeostasis. I've actually just submitted a paper on this topic. Hopefully we'll get published at some point in the future. But the idea is to say, just like blood pressure, blood sugar, body temperature has a control mechanism. If you get too hot, you start to perspire, you start to cool down. If you get too cold, you increase your basal metabolic rate, so on and so forth. How do you control the airway to keep it in balance and equilibrium and in homeostasis? So this is a very kind of interesting paper that came out just a few years ago. And what you see here is a couple of people playing this very long instrument. It's called a didgeridoo. So didgeridoo actually comes from Australia. The Australian Aboriginals play this musical instrument. It's a wind instrument, part of their heritage and culture. And what they found is that people who play this wind instrument is that the sleep apnea actually improves. And so if you read the paper, there wasn't really a good discussion on why or how, what the mechanism involved. But the
Yeah.
finding was that, the didgeridoo is a promising intervention to reduce sleep apnea. Excellent paper, very interesting, and then we put it away.
Yeah.
Well, just last year, another paper came out, and this is looking at blowing a conch shell. And again, it's a traditional instrument, in the Oceania, Pacific Islands, all those great, wonderful places for vacations. But what you see is that they're blowing this conch shell, and what the study showed is the people who blow the conch shell, the sleep apnea, the quality of the sleep actually increased or improved. So now I'm thinking, what does blowing a conch shell and playing a didgeridoo have in common that would somehow affect upper airway homeostasis and how it would affect the AHI? So think about this. You've got this ocean liner. It actually is a fishing vessel or one of those kind of ships, and it's got sonar. And the sonar goes from the surface and sends a signal all the way down. It bounces off the seafloor. It echoes back, and then you get an idea of the terrain under the water there. But the idea here is to send a signal from the surface to subsurface and have some kind of impact or some kind of effect there. Second example here is a fishing vessel, and this kind of vertical fishing net is called a purse seine. And what happens is they use a sonar, there's a kind of shoal of fish there, they drop the net, the fish float, the fish kind of swim into the net, and then what they do is they pull the net, but they actually close it from the bottom. It's like a purse string, like a drawstring, where if you pull the net from the top, the bottom opening closes, and now the fish are trapped. So that is kind of analogy I'm using to explain the new technology I'm developing, because surrounding the airway, we have a network of fascia, the buccopharyngeal fascia. It surrounds the net of the airway here. And when you think about all of these components, it must have some kind of responsibility or function, otherwise it wouldn't be there. So now we have to think about the airway, and we talk about the airway muscles. And classically, these are called the constrictors. They're called the pharyngeal constrictors, which means that they close the airway. The question becomes, in a normal, healthy individual, how would you open the airway? So my idea here is that you've got this fascia, this network of tissue, connective tissue surrounding the muscles. And when they contract, the airway closes. But when they relax, those stretched tissues allow the airway to recoil and open up back to where it was. In other words, when the muscles contract, you store energy in the system, and when they relax, the airway opens. So how do you control that? And the example I gave here is like a hotel lobby. So now you walk into this fancy hotel, and as you're walking in towards the hotel, the doors open automatically in front of you. Why is that? Well, there are pressure sensors in the floor. When you step on those pressure sensors, the doors open automatically. Well, what if the pressure sensors were not working? The doors would not open. And so think about the airway now. If there were pressure sensors in the airway that were not working, when the airway collapsed, it's because the pressure sensors didn't do their job to say, hey, wake up and open up the airway. So my idea here is that the pressure sensors in the airway are deficient or dysfunctional in patients who have sleep apnea. So now the question is, well, can you promote something to help with that signaling? And so I came up with this kind of wearable technology. It's kind of a collar shape. It goes around your neck. They've got a couple of probes on there, and the probes will send a signal down to the airway and say, hey, wake up, because I don't want you to collapse when you are asleep. And so you use that app to control the wearable device here. You wear it during the daytime. You do not wear it at nighttime. So during the day, for maybe 15, 20, 30 minutes per day, just to tone up that airway and make sure that it doesn't collapse at nighttime. You can see here, it just goes kind of around the neck here. Just wear it 15, 20 minutes during the day. When we tried this technique, and we had some preliminary kind of results. It's looking very, very promising at this stage.
Yeah. Yeah. That's awesome. That's so I got so many things from that. Um, One, patients always ask me about different sleep apnea solutions. So now I know I can mention the didgeridoo and the conch shell.
Yes, right.
But wow, so okay. So I see that there's so much of a it looks like there's a different approach, like definitely a different approach you're taking. Like you were
Hmm.
saying to open the airway instead of from back to front, you said from side to side.
Correct, correct. Because the way the airway would like to open is medial lateral, side to side. Now, if the lateral walls collapse, then what you do is you push your tongue forwards and open the airway front to back instead. It's a
Mhm.
bit like when you're walking slowly, you can, breathe through your nose, you're doing fine. Once you start running or jogging, you open your mouth, take a big breath, you open your mouth because that is the compensation you need for that function. So the fact that we can open our mouth, push our tongue forwards is a compensatory mechanism. It's not the basic, mechanism, in my opinion. And we need to do research on that a bit further to say, hey, is this actually correct? But the bottom line here is if we are able to provide a signal that prevents the airway from collapsing using its own control mechanism, that to me is a smart way of helping a lot more people because it's not that expensive. It's a daytime use, okay? There's no adjustments necessary. And so this might be a way of helping a lot more people kind of quickly. We're just at the startup phase right now, very early on, but we are very excited and it's looking very promising at this point.
Yeah, definitely very exciting. And so let's say somebody is listening and they're interested in learning more about it. What would be like the best place to send them to?
Well, we have a little website going. It's called rema-sleep.com. That's REMA-sleep, SLEEP.com. So just go there and it gets the conversation going.
Yeah, all right. So I'll make sure that I link that at the bottom of the show notes. And yeah, definitely excited to see where the technology goes and how things sort of develop there. But so Dr. Singh, do you have any other comments or any other remarks that you wanted to share before we sign off here?
Well, I think, David, you're doing a great job. This is really public service. You're helping a lot of people, increasing awareness. I think that this conversation is where you start. Some people, just don't know, so you educate them. Some people would like to know, so you inform them. That's just all about education, information, and then that communication of saying, let's talk about this and build awareness, and let's make it easy for everyone to get on board. Accessibility, availability, affordability. Do you have access to this healthcare? Is it available in your neighborhood? Is it affordable? Those are the big questions that we have to address. And we won't do everything overnight, literally, but we just chip away at this, point by point, and eventually the balance will tip in our favor. And I think the, service that you are providing, both as a professional sleep tech, is invaluable because every team member plays a vital kind of role. And without the sleep techs, boy, we would be in a really difficult situation. And what the sleep tech is doing is on the front end, the diagnostic side of things, but on the back end, helping patients with managing their form of therapy. So as you said, it's kind of the glue that puts all of these components together. And so it's an incredibly important service that you're providing. And I'm very grateful that you've had me on here today. And we should do this more often.
Yeah, definitely. It was a great conversation, and I really appreciate you sharing what you're up to, sharing your knowledge through the years that you've been in the industry. Just off the few conversations we've had, I've learned quite a bit, and even before meeting you, just reading some of the work that you've done. So I really appreciate you sharing. I've got a lot of new rabbit holes to dive into and explore more. So,
Yeah.
Dr. Singh, great conversation. And everyone, thank you for joining us on the Scaling Sleep Solutions show. And we'll see you next time with some new exciting technologies and another great guest. But Dr. Singh, all right, take
Bye-bye.
care.
Bye.